Welcome back to the Deep Dive.
Great to be here.
This is where we take your source material, could be articles, research, maybe like today, your own revision notes, and we just dive right in.
Yeah, we pull out the absolute core stuff you need to know.
Think of it as, a way to get properly informed fast with the facts that actually stick.
And we're here to sort of guide you through that pile of information, help you spot the really key nuggets.
Understand not just what the facts are, but maybe why they're important, especially if you're prepping for something like the MSRA.
Exactly.
And that's just what we're doing today. You've sent us this brilliant stack of specific MSRA revision notes, all focused on cervical cancer. Really crucial topic.
Absolutely. So our mission really is to take these notes and turn them into, a high-yield, clear guide for you.
Perfect for revision, yeah. Or just getting a really solid handle on this.
Totally. We're going to distill everything, right from the basics, all the way through diagnosis, management, the outlook.
Based only on the notes you shared.
Strictly on the notes. The goal is making these key points memorable, easy to pull up when you need them.
Okay, so let's do it. We're diving deep into cervical cancer. Definition, causes, risks, how it develops, what else it might look like.
Who it affects, how it presents, tests, treatments, prognosis, complications, the whole lot.
A proper sweep designed for, efficient revision. Let's get started.
Okay, let's unpack this stack, starting right at the top, the definition. What do your notes say it actually is?
They describe it simply as a malignant growth of cells in the cervix. That's the lower, narrow bit of the uterus connecting to the vagina.
Right, simple enough. And the next really crucial thing the notes hit on is how it develops.
Yeah, they say it's usually slow. Takes years, often.
And the big link, the primary cause they mention.
Persistent high-risk human papillomavirus infection, HPV, that seems key.
Absolutely fundamental. You need to know that HPV connection. And for context, in the UK, your notes put it as the 14th most common cancer in women.
Which sounds, not super high compared to some others.
Maybe not, but here's a stat from your notes that caught my eye. 75% of cases in the UK are diagnosed early, stage I or II.
Oh, wow. 75%. That's actually quite encouraging, isn't it?
It really is. Suggests screening is having an impact, which we'll definitely come back to.
And it's not just an older person's disease either, right? The notes say about half of cases are in women under 45.
Yeah, absolutely relevant across a wide age group. Your notes also split it into the main types.
Ah, yes. Squamous cell carcinoma is the big one, about 80%.
Around 80%, yeah.
Yeah.
And then adenocarcinoma makes up most of the rest, about 20%.
Okay, just pausing there. We've got malignant growth, cervix, low development, HPV link is massive, 14th common in UK. But 75% caught early affects younger women too, mostly squamous cell. If you had to pick one absolute must-know fact from that intro.
For revision, that persistent HPV link, non-negotiable. And maybe that 75% early diagnosis stat, because it tells a story about screening effectiveness.
Good point. Which leads us neatly into etiology, the causes. What do the notes say beyond HPV?
Well, HPV is the primary cause. Persistent infection with high-risk types. They specifically name HPV 16 and 18 as the main ones.
Right. 16 and 18. Got it. But there are other factors mentioned, too.
Yeah, other things that contribute, like having a weakened immune system.
Okay.
Smoking is on the list. Starting sexual activity early, having multiple partners.
Right, the sexual history factors.
Yeah, and using oral contraceptives long-term.
So those contributing factors then build into the full list of risk factors the notes lay out?
Exactly. The risk factor section just expands on that, making it clear who might be more susceptible. HPV infection is right there at the top again.
Still blaming types 16 and 18 for about 70% of cases?
That's what the notes say, yeah, around 70%. Then they list the others, maybe grouped a bit for easier recall.
Okay.
Weakened immune system, they give examples like HIV, or maybe after an organ transplant.
Makes sense.
Smoking, definitely a modifiable risk. Then those sexual activity points, early start, multiple partners.
Grouped together, yeah.
Long-term oral contraceptive use, and then some demographic or access things. Being heterosexual, lower income.
And a critical.
Not attending cervical screening. That's a big one.
That is a big one. It's quite a list to remember for risk factors. Maybe for revision, you could try grouping them, like modifiable ones. Smoking, screening attendance.
Yeah, or maybe a mnemonic for the key ones. Smoking, immunosuppression, sexual history, OCPs, non-attendance, SIS on, something like that might help it stick.
Whatever works for you. And you can see how they test this, right? Give you a patient story.
And ask you to spot the risk factor she doesn't have based on this list. You need to know them.
Definitely. Okay, so we know what it is, who's at risk, how does it actually develop, the pathophysiology bit in your notes.
Right. It starts, according to the notes, with those precancerous changes, linked directly to that persistent HPV.
This is where CIN comes in, cervical intraepithelial neoplasia.
Exactly. And it has stages, CIN9, I2, and 3. They represent increasing levels of change in the epithelium, the surface layer.
But it's not cancer yet.
Not yet. The crucial step to becoming invasive cancer, the notes say, is when those abnormal cells break through the basement membrane.
Ah, okay. And they distinguish between microinvasive and invasive.
Yeah, based on depth. Less than 5 millimeters deep is microinvasive, more than 5 millimeter is invasive.
Interesting. The notes here give slightly different numbers for the types than the intro did. Squamous 70%, mixed 15%, adeno 15%.
Good spot. Shows you need to pay close attention to the specifics in your source material. Details matter.
Absolutely. And the typical diagnostic pathway they describe.
It's logical. Starts with screening. If that's abnormal, either the cytology or the HPV test, you get referred for colposcopy.
That's the closer look with a microscope thingy.
Yeah, magnified view. And then usually a biopsy is taken during colposcopy to get tissue and confirm the diagnosis.
Makes sense. But if someone actually has symptoms, it might not be cancer, right? What about the differentials?
Good point. The notes list quite a few things that could cause similar symptoms, especially bleeding or pain. Well, CIN itself, the precancer stage. Other gynae cancers, endometrial, vaginal, vulvar, PID.
Pelvic inflammatory disease.
Right. Cervicitis, dysfunctional uterine bleeding, cervical erosion, even things like endometrial hyperplasia, fibroids, or atrophic vaginitis in older women.
Okay, quite a range. But you can see the overlap, can't you? Bleeding, discharge, pain. Could be many things.
Exactly why a proper workup is needed. Now let's loop back to the numbers. The epidemiology section adds more detail.
Okay, so UK stats again, 14th most common.
Around 3,200 cases a year.
And that 75% stage I or II detection rate again, that seems really key.
It is. And the age profile. Over half under 45, highest incidence 25-29, peak diagnosis 30-34, and that link to lower socioeconomic backgrounds again.
But the global picture your notes paint is much starker, isn't it?
It really is.
Yeah.
Globally, based on 2018 stats in your notes, it was the 4th most common cancer overall.
4th? That's huge.
Yeah. 570,000 cases, 311,000 deaths. Your notes say it's a leading cause of cancer death in African regions. Average age of death globally is 59.
Wow. The difference between 14th in the UK and 4th globally, that's massive.
It is. And your notes mention UK screening detects 30% of cases, which definitely contributes to that difference compared to places without widespread screening or vaccination. Really highlights the impact of public health measures.
Definitely food for thought. So, okay, clinical features. If screening doesn't pick it up first, how does it present? What symptoms should you look for?
Well, the first point the notes make is that screening often catches it before symptoms start.
Right, the ideal scenario.
But when symptoms do show up, the common ones are abnormal vaginal bleeding, and they really flag postcoital,
After sex,
intermenstrual,
between periods,
and postmenopausal bleeding. Those are key. Also, maybe increased discharge and pelvic pain.
And the notes mention late symptoms too.
Yeah, suggesting more advanced disease. Things like weight loss, fatigue, blood in the urine, painless hematuria, urinary frequency, rectal bleeding, changed bowel habits, leg swelling.
Sounds like it's spreading locally or further afield.
Exactly. And on examination, a doctor might actually see something abnormal on the cervix or vagina, maybe a mass, or notice bleeding or swelling. The notes specifically call out blood-stained discharge and abnormal bleeding as key red flags.
Got it. The notes also slip in a mention of the HPV vaccine here, covering types 16, 18, 6, and 11 in England.
Yeah, tying prevention back in.
Yeah.
And reinforcing that screening aims to catch those premalignant lesions, the CIN.
When revising, it might be useful to sort those symptoms in your head, which ones are early warnings, like the bleeding types, versus the later signs like weight loss or leg swelling.
Good strategy. Helps prioritize. Now, the investigations and screening section, this is dense, but absolutely vital for the MSRA.
Okay, break it down for us, the UK screening program.
Central, ages 25 to 64.
Intervals.
3 yearly from 25 to 49, then 5 yearly from 50 to 64. Gotta know those.
Any exceptions?
Yeah, pregnancy, wait till 3 months postpartum. Non-sexually active women can opt out. And a key point, screening is less good for adenocarcinomas, maybe misses up to 15%.
And the technique has changed, hasn't it? From pap smears to
liquid-based cytology, LBC. The notes say it's better, fewer inadequate samples, more sensitive, and ideally done mid-cycle.
Okay, now the really crucial bit, The modern HPV primary testing pathway. This sounds complex.
It is a bit of a flowchart, but you need to grasp it. So, step 1, test for high-risk HPV.
Okay.
If that's negative, back to normal recall, usually.
Simple enough if it's positive.
If HPV is positive, then they look at the cytology from the same sample.
Ah, so HPV first, then cytology if needed.
Exactly. If cytology is abnormal and HPV is positive, that's a direct referral for colposcopy.
Makes sense. Abnormal cells plus high-risk virus. Take a closer look.
Right. But here's the twist. If HPV is positive, but cytology is normal,
What then? No referral.
not straight away. You get retested in 12 months.
Okay.
If HPV is still positive at the 12-month retest, you get retested again at 24 months.
Still no colposcopy if cytology is normal.
Not yet. But if HPV is still positive at that 24-month mark, even with normal cytology, then you get referred for colposcopy.
Ah, okay. So persistent HPV infection alone, even without visible cell changes after 2 years, triggers a closer look. What if HPV becomes negative at 12 or 24 months?
Back to normal recall.
Got it. And inadequate samples.
Repeat in 3 months. If you have 2 inadequate ones in a row, that also leads to colposcopy.
Okay, that whole pathway. Definitely high yield. Drawing it out would probably help.
Absolutely. Visuals are great for pathways. So colposcopy is that magnified look at the cervix, triggered by screen results or clinical suspicion.
And the biopsy confirms it.
Confirms a diagnosis, yeah.
Yeah.
Give the subtype too.
What about staging? What imaging do the notes mention?
CT of the chest, abdomen, and pelvis with contrast is preferred according to these notes. PE scans are also mentioned, especially for looking for distant spread.
Other tests.
Chlamydia testing for younger women with abnormal bleeding, and an urgent referral for any postmenopausal bleeding.
And sometimes an examination under anesthesia or EUA.
Yes, the notes list things done during an EUA. Various exams, abdominal, vaginal, rectal, scopes like colposcopy, hysteroscopy, cystoscopy, sigmoidoscopy, and biopsies. It's for a thorough assessment when needed.
Right, let's tackle staging properly now. FIGO staging, key for management and prognosis.
Definitely a must-know. Your notes lay it out.
Stage 0.
No primary tumor. TISB is carcinoma in situ, just on the surface.
Stage 1.
Confined to the uterus,
Yeah.
specifically the cervix.
Stage 2.
Invaded beyond the uterus, but not hit the pelvic wall or the lower third of the vagina.
Stage 3.
Now it has reached the pelvic wall, or involves the lower third of the vagina, or it's blocking a ureter causing kidney swelling hydronephrosis.
And stage 4?
Spread to nearby organs like the bladder or rectum, or distant metastases spread far away.
Okay, maybe visualizing it helps, like ripples spreading out, just
Take some
cervix
time.
a bit further but contained, hitting the outer edges, 3 going everywhere.
That's a good way to think about it anatomically. And remember that key stat, again, most are diagnosed early, stage 1 or 2. You will be tested on staging, so know what each stage means. They might describe findings and ask you to stage it.
And before we get to invasive cancer treatment, what about CIN management?
Right, the pre-cancer stage. Notes mention surveillance for low-grade changes, but for higher-grade CIN, excision is common to prevent progression.
Like LLEA.
LAVTC is common, yeah. Large loop excision of the transformation zone, often done during colposcopy. Cryotherapy is an alternative mentioned. This is treating the pre-cancer.
Got it. Okay, now managing actual diagnosed cervical cancer. Notes say it depends on lots of factors.
Yeah, very individualized.
Yeah.
Stage, age, other health problems, patient preference.
So for early localized disease.
Surgery is a main option. Could be a cone biopsy for very early stage, or a hysterectomy. Radiotherapy is another option.
And for more advanced cancer.
Combination treatments usually. Chemo, radiotherapy, maybe immunotherapy are mentioned.
Palliative care for advanced cases, too, for symptoms.
Yeah.
And what about pregnancy?
Tricky situation. Notes say treatment might be delayed, or therapeutic abortion considered, depending on stage and how far along the pregnancy is. A really important point for younger women mentioned in your notes is fertility-sparing surgery.
Ah, yes, the radical tricholectomy.
Exactly. For early-stage disease in women who still want the option of having children. Key detail.
The notes give surgical examples by stage 2.
Yeah, like cone biopsy or simple hysterectomy for the very earliest, stage IA1. Then radical hysterectomy plus removing lymph nodes for stages like IB and IIA. They also mention minimally invasive surgery options.
And radiotherapy details.
External beam radiation plus internal radiation, called brachytherapy. Notes say this combo improves survival, and often given with chemoradiation for stages IB2 up to the third.
Okay, chemoradiation for locally advanced and chemo itself.
Usually cisplatin-based, notes say, used in different ways, after surgery, adjuvant, with radiation concurrent for symptoms, palliative, or sometimes before treatment, neoadjuvant.
What about follow-up after treatment?
Interestingly, your notes say there's no universal agreement. But crucially, smear tests, cervical cytology, are not recommended for follow-up after cancer treatment.
Oh, really? So what happens?
Notes mention returning to annual population-based screening after 5 years if there's no recurrence. But that's part of the general screening program, not cancer follow-up per se.
Okay, so key management takeaways. Treatment based on stage. Fertility-sparing option is vital for some. Chemoradiation for locally advanced. You could definitely get a question asking for the right management for a specific stage.
Absolutely. Now, the outlook prognosis. Notes sound reasonably positive overall.
Yeah, they explicitly mention improving survival in England and Wales, thanks to better treatment and detection.
The overall stats are pretty good. Over 80% survive 1 year, over 65% at 5 years, and still almost 65% at 10 years.
What affects prognosis most?
Stage at diagnosis, that's the biggest factor according to your notes. Histology type, socioeconomic status, and age also play a role.
Okay, here are those critical 5-year survival rates by stage from the notes. Definitely high yield.
Let's hear them.
Stage IA1, 100%.
Amazing for the early stage.
Stage IB2 by IB, 50 to 70%.
Still pretty good odds.
Stage 3 drops to 30-50%.
Okay, getting tougher.
Stage 4, only 5-15%.
Wow. That's a stark difference, isn't it? From 100% down to potentially 5%.
It absolutely hammers home the importance of catching it early through screening and recognizing symptoms.
Totally. That's probably the most powerful statistic in the whole set of notes. For revision, definitely link those stages to those survival ranges.
Yeah.
Flashcards, mental image, whatever works.
Yeah, expect a question. Patient has stage 3 cervical cancer. What's the approximate 5-year survival? You need to know that 30-50% range.
Definitely. Okay, nearly there. Just a quick mention of complications listed in the notes.
Right, potential problems.
Cancer spreading locally, invading nearby tissues.
Or metastasizing, spreading distantly to lungs, liver, bones.
Recurrence after treatment is a big one. And then the side effects of treatment itself, surgery issues, radiation damage, chemotoxicity.
And the emotional impact, of course.
Yeah, can't forget that. It underlines that even with good survival for early stages, it can be a tough journey due to the cancer and the treatments.
Okay, so that's the run-through. We've hit a definition, causes, risks, pathophysiology differentials, epidemiology, UK versus global, clinical features, that detailed investigations and screening section.
Management options including fertility sparing, prognosis based heavily on stage, and potential complications, all pulled directly from your notes.
Yeah, this whole deep dive was designed to take your specific MSRA notes and talk through them, hopefully making those high-yield facts stick better.
We really hope hearing it discussed helps lock it in. Maybe go back to your notes now, highlight the bits we stressed, see if it feels more connected.
Before we finish, just a final thought to leave you with, building on what we've discussed, especially that global disparity.
Yeah, think about it. Your notes show how effective HPV vaccination and screening are in places like the UK. But they also show how devastating stage 4V disease is and how much bigger a problem this cancer is globally.
So the thought is, what's the real potential if we could get those prevention tools, the vaccine, effective screening, out to everyone, everywhere, especially in regions where it's currently a leading killer?
Could we genuinely change the landscape of this cancer worldwide? Maybe even head towards eliminating it as a major public health threat.
Something to mull over, using the knowledge from your notes. A huge thank you for bringing these notes to the deep dive.
We really hope this session helps with your revision. Keep putting that knowledge into practice.
And remember, for more resources linked to this kind of material, you can check out passthemsra.com.
And for free MSRA resources, don't forget freemsra.com.
Until the next time we dive deep, keep learning.
Keep exploring.
And stay curious.